are dependent on those funds. So this is a threatening concept of changing the formulas, but it's something that got a lot of traction. We also realized that the net impact of screening within a hospital or other settings is really poorly understood. Most people believe that the federal funding for GME supports only a small fraction, maybe less than a quarter of the costs of GME, but there are certain other aspects of GME funding, like the offset of other personnel costs, that make the net impact very difficult to pin down. We also agreed that federal funding for GME, if it were to increase, wouldn't necessarily solve the problems in terms of getting the right number of docs or the right distribution across geography or across specialty, and that increasing funding isn't necessary for getting more GME slots into the system. Because when we look back over the last decade, as you know, there was a cap on GME funding put in place based on 1996 levels of residence, and despite that cap, institutions have added more and more slots. And in fact, the rate of increase hasn't changed over the last decade compared to the decade before. So we couldn't make the argument that if we need more docs and we need more GME slots, that will require an increase in funding, because history doesn't support that. So what was the gist of the committee's recommendations? First, that we maintain a secure flow of funds that's predictable. Hospitals need to make long-term commitments to residents, at least for the next decade, at current levels with an inflation adjustment. We did not have a consensus that allowed us to make this statement without the qualifier that it be reviewed after a decade. Another important aspect of the recommendations was that we fix the formula, and I'll in a minute say more about that, and overall that we move from a cost-based formula to value-based funding to work in parallel with how healthcare at large is being funded based on value and quality rather than volume. We wanted to leverage this federal funding that we're lucky to have to incentivize and facilitate innovation, make the process of GME more effective and more cost-effective. We wanted to minimize problems from the funding shifts, again, by having some iterative implementation, and decided to leave Medicaid at the state's discretion. So there's no new recommendation relating to Medicaid. And finally, which I'm not going to talk about any further unless you have questions, implement a new system for oversight of GME and for oversight of the funding. So, how would this play out? It would necessarily happen in two phases. The first phase would be the merging of the current IME and DME funds flow into an operational fund, which would distribute dollars to hospitals based on the existence and location of slots as they currently exist. And that would be distributed based on a single payment that would be equal across the country, importantly with a geographic adjuster based on the cost of living index. But it would get rid of this historic formula where some hospitals, even hospitals in New York down the road from each other, may have very different GME payment rates based on what their historic costs were 30 years ago. So that problem would go away. Part of the funds, a minority of the funds, maybe 10%, and perhaps for a couple of years as much as 30%, would be funneled into a transformation fund. That would be, in effect, an R&D fund to support innovation in GME. And the money coming to R&D would, in fact, be spent at teaching sites, at teaching hospitals, ambulatory sites, other places, in a way that would help us do demonstration projects, large-scale controlled trials to figure out how different approaches to teaching compare, and also to figure out how different payment incentives can work. So if we had an idea that we needed to incent institutions to create more primary care slots, could we pay more for a primary care slot than we do for a surgical slot, and would that help, and would that result in a growth in the number of slots, and could they be filled? That would be the kind of project that the Transformation Fund could support. not advancing here. So while somebody helps with that, I will keep talking. So the impact of these changes is important to try and figure out. Someone's coming for this slide right now, thank you. So the impact would be several-fold. First, in terms of the short-term impact, the children's hospitals, thank you, that are now left out in the cold would be part of this new payment system. Currently, independent children's hospitals don't get GME funds in the same way that everybody else does. They get a smaller amount of funds through a different payment stream, and they are subject to annual appropriations, which other teaching sites are not. A third, almost a third, of the pediatricians in this country are trained in freestanding children's hospitals, and so they would now be part of the system. Another important implication is that hospitals will need to adapt to change in funds flow. And some may feel a cut of 20-30% even if they're at the high end now of the annual flow of GME dollars. They would have the opportunity to recoup some of that potential loss by participating in trials in this and getting money through this transformation fund. The amount that an individual hospital might lose would be dependent on how much they're getting now, what their historic costs were, the percent of Medicare patients they see, which now drives the formula and would not going forward. Also, another important change would be the funds would flow to the sponsor of the program, not to the site where the resident trains. So if we train residents and we send them to another hospital for a few months, the funds associated with that go to that other hospital. The current system also, as I'm sure you're acutely aware, disincents placing residents in ambulatory training sites, and that disincentive would importantly go away. So the program director would control the funds, the institution and the program director, and would be able to design a program based on educational needs and curricular priorities rather than funds flow mandates. This would also allow needed research to get underway based on the transformation fund, and this threat that comes up in the budget nationally every year about taking away the IME would become moot because there wouldn't be any more separate stream that serves as a target for cuts. Phase 2 would be different. Basically, we would distribute the funds through the operational fund according to quality and outcomes rather than the historic distribution of funds. So in this vision, a hospital couldn't count on having some number of positions 20 years hence unless they show that they are accomplishing what GME is supposed to accomplish. More on that in a moment. We would have ongoing R&D at a lower level perhaps once we reach steady state, but we would be achieving a system that's flexible and nimble in a way that our current system isn't. The current rules that have been in place about 30 years have really straitjacketed us in terms of innovating. So we would have a system where outcomes data is continually evaluated, and it would feed back into how the funds are distributed to different training programs and institutions. The payment incentives would change over time, probably not on a yearly basis, maybe every decade, based on better and better projections that we would be able to make. And then the funding shifts would be implemented gradually. 10 years from now, we would have to reevaluate this in order to continue to justify getting this funding at all. But hopefully at that point, we would have a much better level of documentation and be able to go forward without this axe hanging over us in terms of the federal funding. So in considering the possibilities of this, I think there's a lot of room for optimism. This would be a new, secure pot of funds through the Transformation Fund for medical education research, which has been an obvious lack in our system up till now. It would allow us to tackle major questions. Questions like, should we have time-based training or competency-based training? because 50 or 70 years ago somebody decided it takes 5 years to train a general surgeon, we haven't re-examined that. There could be ways to train physicians quicker, more effectively, and we need to figure out what those methods are. It would also allow us to provide coordination for research, get exemptions from ACGME and other regulators to be able to do the kinds of studies that we want to do, collect data together, and apply the same continuous improvement mentality to GME that we do to care. What needs to be done to get to that point? We need better workforce data. We need to plan pilots. We need to get together as a community of educators and prioritize the questions that we want to ask. We need to figure out what the metrics would be, because if we're going to assign slots to institutions based on how well they do in GME, how are we going to measure that? I think everyone would agree that the most important outcome is the quality and the cost and the value of the care that our graduates deliver, not what they're doing as residents, but what they do when they leave us. We don't have a way of measuring that now, but in this era of health IT and big data, I can't imagine that we wouldn't be able to do that a decade from now, when we would need to start preparing for that now. We would need to figure out the type of practices and the location and the volume of care our graduates are delivering after they leave our institutions. And I think institutions that are focusing also on research would want to have one of the outcomes be the extent to which our graduates are advancing the field. And then finally, other societal contributions. So at the institutional level, what do we do to prepare for this? I think we need a better understanding of financial impact of GME. It's likely to vary by specialty, by level of training, by the site, ambulatory versus inpatient. And in order to prepare for any kind of funding shift, I think an institution is going to want to start looking at its books more carefully. We want to create some good approaches to funding, like fellows. Fellow funding is already thin and has always been under a greater threat than residency funding. We want to reconsider at the institutional level, what's the right size and the number of programs? It shouldn't just be as a way to take care of the patients that come through our doors, but based on the GME mission itself. What's the right proportion of residents and fellows in a given specialty? And what's the right mix in an institution for slots in the different